Good evening to all. Today I will be taking a lecture for you on urinary diversions. So this is one of the most important chapters from your Campbell, and it is few chapters that are difficult to understand from Campbell if you read for the first time. So my job would be to tell you about the important MCQs from this chapter and also to explain to you about the basic concepts on the urinary diversions. So how will we proceed? So I would split this chapter into 7 parts. The first part would be on introduction and the history. The second part on the bowel segments which are used. The third part on stoma. The fourth part on ureterointestinal anastomosis, the fifth part on continent cutaneous diversions, the sixth part on orthotopic neobladder, and the seventh part on the continence mechanism. So before we jump into the topic proper, you should understand what is the definition of the urinary diversion. So in a layman term, a urinary diversion is to divert the urine outside a human body after you remove the urinary bladder for any purpose, the most common purpose being radical cystectomy for CA bladder. So in Campbell words, urinary diversion means it is a bypass or reconstruction to replace the urinary tract after you remove the urinary bladder or after you do a procedure called cystectomy. So what are the indications of the urinary bladder? As I told you, urinary diversion is a procedure which is done after your bladder is removed, the most common reason being for CA bladder, or when there is any sphincter or detrusor muscle damage or any neurological control to your lower urinary tract system is lost. And the third indication being irremovable obstruction to the bladder or distal to the bladder. For example, any stricture urethra which has been operated many times and still the patient is not able to void via naturalis, then you remove the bladder and you replace the bladder with a urinary diversion procedure. The fourth indication being ectopia vesicae, and the fifth indication being incurable genitourinary fistula, for example, and vesicovaginal fistula. So the indications are when the bladder is removed, when there is an irreplaceable damage to the sphincters or the detrusor muscle, or when the neurological damage to the lower urinary tract system is lost, or when there is an irremovable or irreparable obstruction in the bladder or distal to bladder, the ectopia vesicae, and incurable genitourinary fistula. So before we enter into the topic proper, you should understand the classifications of urinary diversions. So urinary diversions can be classified basically into two broad types. One is the cutaneous diversion and one is the neobladder. So first, before I start this, you should understand what do you mean by heterotropic and what do you mean by orthotopic. Heterotropic means in another position. Orthotopic means in natural position. In other words, if I remove the bladder and I replace a structure similar to bladder in the same natural position, that is, I remove the bladder from the pelvis and replace some structure equal to bladder made in the pelvis, then it is called orthotopic. Heterotropic means in another other than the natural lying position. That is, I create a bladder in the elsewhere than the pelvis, then it is called heterotropic. So after you understood the terms heterotropic and orthotopic, the cutaneous diversions, then you should understand the two broad categories of the urinary diversion. So there are two types of the urinary diversion. One is cutaneous diversion, one is orthotopic neobladder. Cutaneous diversions are equal to your just like your fecal diversion, like how you make ileostomy, colostomy, sigmoidostomy. Similarly, you resect a bowel segment. One end of the bowel segment is attached to the ureters, and the other end of the bowel segment is brought out to the cutaneous of the skin to outside. So this is called cutaneous diversion. So orthotopic neobladder means you, as I told you, the word orthotopic means replacing the bladder in its natural position. So you create a bladder-like structure from the bowel segment and you replace it in the pelvis or place it in the pelvis and one end of this orthotopic bladder is connected to the two ureters. The other end of this orthotopic neobladder is connected to the urethra. Now the patient voids via the naturalis, that is via the external urinary meatus. Now coming to this slide, you can see there are three types of the urinary diversion. The type A on the extreme left, you can see what is called as a non-continent cutaneous diversion. The word non-continent means there is no continence mechanism. So the urine is constantly dribbling via your external stoma and to the outside. So this is an example of non-continent cutaneous diversion. If you see, an ileal segment has been resected and one end of the ileal segment has been connected to both the ureters. The other end of the ileal segment is brought out through the belly of the rectus muscle in the right iliac fossa to the outside the skin, and now the urine will come out through the stoma which is present in the right iliac fossa without any continence mechanism. So the type A, the figure A shows you non-continent cutaneous diversion. The type B shows a continent cutaneous diversion. That is, a bowel segment is harvested. It is made to look similar to the bladder, but it is in the heterotropic position. That is, it is not present in its natural light. It is elsewhere than the pelvis, and this pouch is attached to an efferent limb. The one end of the efferent limb is attached to this pouch. The other end of the efferent limb is brought out again as a cutaneous stoma in the right iliac fossa. But in the difference between type A and type B is type A is non-continent, but type B is fully continent. That is, it doesn't dribble urine all the times, but it dribbles urine only in appropriate and correct time. And type C is orthotopic neobladder. As I told you, the word orthotopic means in its natural position. So wherever the bladder was present and that bladder is removed, then we create a neobladder using a bowel segment, and this bowel segment to one end is attached both the ureters, and the other end of this bowel segment is attached to the urethra. So now the patient voids under the continent mechanism of the external urinary sphincter, and now the patient voids via the naturalis. So now that you understand the two broad categories of classification of urinary diversion, that is cutaneous stomas and or the cutaneous diversions and the neobladder, and cutaneous diversions are further classified into orthotopic and also heterotopic. Now you should understand where do we stand in the present era. So, as I told you, the third type, that is the orthotopic neobladder, is the most common procedure. So, it accommodates to total of 50% of total type of all the types of the urinary diversion. But you should also understand, if you do radical cystectomy for CA bladder in 100 patients, 40% of the patient do not fall into the inclusion criteria for orthotopic neobladder. So what do? We have another few choices. So what are the other two choices we have other than the orthotopic neobladder? We have non-continent cutaneous diversion and also continent cutaneous diversion. So the second most common type of the urinary diversion is the non-continent cutaneous diversion in the form of the ileal condo, which totals up to 30% of the total type of the urinary diversion. And the last type, that is the continent cutaneous diversion, will accumulate to about 20% of the total type of urinary diversion. So the important MCQs from this slide is, most common type of the urinary diversion is orthotopic neobladder, followed by non-continent cutaneous diversion, that is ileal condo, which is about 30% and comes to be the second most common, and 20% is the continent cutaneous diversion, which is catheterizable, which comes in the third position. So some of the important salient MCQs which they can ask in history of these diversion procedures are: uretrosigmoidostomy is the oldest form of the urinary diversion. What is uretrosigmoidostomy? In simple terms, after the bladder is removed, the ureters will be dangling in the peritoneal cavity. These cut end of the ureters are anastomosed to the sigmoid colon, and now the urine and feces will be passing through the anal canal, but under the continent mechanism of the anal sphincter. So this